So, Anne referenced Lord Carter earlier and said in the report a few years ago, multiple recommendations, and one was around model hospital. We sit on a plethora of data that can inform us a lot about how we deliver care and how we can deliver it better in the NHS for our patients and for the taxpayers. And yet we used that taxpayers' money to purchase analytical skills from the private sector, from consulting firms and the like. Then Lord Carter essentially said, well, no, we have that data and we have the capability to look at it ourselves. And from that, Model Hospital was born 2 weeks ago, we celebrated our 3rd birthday. And for those of you who logged on to the initial versions will have seen just how much has transformed from a relatively small website, not particularly slick, to something very different now with over 10,000 metrics in it. Now, I've not seen all 10,000 of those metrics. I don't expect all of you to have seen all 10,000 of those metrics. And my hope today is to talk through a little bit about what that site looks like now and answer a question I get a lot, which is, okay, well, I lead the nursing teams in my trust. Where do I start with this tool? So the key purpose for Model Hospital at whatever level you are at in a trust is the same as a PDSA type cycle. You can use it initially as a planning tool. You start developing schemes off the back of it. You study what you've done, and you act upon that. And we've got a couple extra steps in here to make it specific for Model Hospital, but the principles are largely the same. Now, what tends to throw a lot of people, though, is we'll say, okay, start somewhere around the cost per wow. And people know what cost is, people don't always know what a wow is. There is a YouTube video, and when this gets sent around, I urge you to click on that link and have a look at it for a more detailed explanation. But in very simple terms, you come from a variety of different hospitals, from small DGHs to large tertiaries, and you deliver very different types of care. What we found that the average cost of delivering something in the NHS, whatever that may be, is roughly around £3,500. And what we're trying to do is say, right, whether you're sticking plasters on patients or, doing organ transplants, we want to try and index everything around that 3.5 and say, right, well, if you're doing lots of one or a tiny bit of the other, well, you're kind of in that same sort of area. Now, it's obviously more useful when you start looking at it specialty level because you'll have more similar operations in that area. But it does work as a simple guidance at trust level. And something I'll say is quite important here is when you do look at a cost per wow, when you look at the opportunity number, don't take that as gospel as that is the number. Obviously, it depends on the quality of the reference cost behind it, but it is a useful guide, especially when you're looking relative to your peers, as to where you should be looking at whatever it is you're looking at. So as I mentioned, we've come a long way in 3 years to create a new version of the site, which better highlights where you can find opportunities and also, get the data refreshed on a more timely basis, develop more useful metrics based on the feedback we've received from various organizations, and try to make it more transparent. So improve, when you click on the metric and you look at the metadata behind it, making sure you got a better sense of where we get our data from and how it's calculated. And for those of you who are on the road a lot or working out in communities, then you can use this on your mobile phone or tablet as well. So I was logging on earlier just to make sure that the trust and the data I'm about to present you is in the format I thought it would be. Now I will skip over some of these because I will do a live demonstration in a moment. Just wanted to go through some of the feedback that we'd received about the new site, and it's received a lot of positive feedback, and we had a couple of suggestions to make improvements, which I'll show you some of the things we have responded to. I just wanted to go through my favorite quote on here, which is the second one on the right-hand column. The new version is far more intuitive. The addition of context information, e.g. in the AHP compartment, is fantastic. That data was always there. before we redesigned the website. So for those who have used the new website, I hope you find that it is a lot easier to find some of that data using search tools and the like. Now, I am going to skip towards the end and then just jump down to the live version. So I am still logged in, thankfully. It's not been more than an hour since I last logged in. So I've got a test trust lined up here. And the way new website works is we try to point people to the opportunities area first. So this is primarily driven around the cost per wow figures. And so if I click for this test trust into workforce, we've got some information here about how it's identified, and I think we disable this for the test trust. Right, never mind, sorry. But if you did that for your trust, what it would do is it would show you a series of different workforce metrics based on different categories, so substantive staff versus non-substantive staff, AHPs, doctors, and so on. And it will sort of show, okay, right, well, you got this overall figure of about 10 million. Which bit of the calculation is going to show you that. Beyond that, we've got breakdowns going by, depending again on who the key people are who would want to review things. So you've got board level oversight for those at the top of the organisation who just want a general overview. Combination of care settings and clinical service lines, which combined sort of give you a view at specific specialties. And I'll come back to this in a moment when I go through another example. Some of the support services behind that. Some of the back office functions, which can work in slightly different ways depending on whether you have consolidated back offices or run your own functions. But of course, we're here to primarily talk about people. And what I suggest to a lot of people is, well, if your focus is workforce, then start with the workforce analysis compartment, because this gives you a really nice overview of, just making sure that the data that we are using, which is primarily driven by ESR, particularly for the substantive data, because that is what it records, will, do those FTE numbers look right for the size of the trust that you are? Does it look right compared to your recommended peers? And does it look right for the other staff groups? And if those numbers look correct to you, then it actually gives you some other useful bits of information. It says, right, well, based on that weighted activity I spoke about earlier, how much activity are you delivering per member of staff that you have? Obviously, this is a very crude metric because it's looking at every different type of activity, irrespective of who delivers it. But again, it's a decent starting point to see where you may have opportunities to either move staff around or look at changing skill mixes and the like. And similarly, you've got your cost per wow figures as well in there. And speaking of skill mix, so if I drill into, where is it? FTE per band, sorry, skill mix ratios. So some of the useful ratios in here are sort of looking at how, again, at an overall basis, how are you structuring your organisation? What do the nurses to consultants look like? And when we start getting better data on your ANPs and the like, can we start showing what those ratios look like and how does that look relative to your peers? And what are the clinical outcomes that leads to? And for those clinical outcomes, you can start then looking at other bits for the staff groups you're primarily concerned about. So if I look at nursing and go into trust level, I've spoken a little bit about finances type stuff so far, but of course, there's far more to delivering care than that. So every month we update data on friends and family test to see, how are you performing over time? So you can see there's a slight downward trend to how much the inpatient services are recommended. Obviously, there are some data that aren't received, and where you have those situations, you have no data available, but I'm sure for some organisations you'll have more there. And if you are a community and mental health trust, then there is also more data available through that drop down as well. Little bits on finance and care hours per patient day. Be mindful of using the trust level care hour per patient day number. Imagine you're a hospital with 1 ITU and you're comparing yourself to a hospital with 2 ITUs. Well, an ITU is naturally going to have very high care hours per patient day. It's required to have a very high level of care hours per patient day. And as a result, your peers may look considerably larger. And I'll show you the ward level compartment in a moment where you can split out your specialty and you can split out critical care medicine, and then you can do that comparison in there. And that'll be far more useful to you than trying to look at the trust level figure. The reason we present the trust level figure is that there can be some useful information around aligning that to your cost per care hour and your cost per patient day, just to see whether those figures triangulate to your overall cost per WOW number and to your average staff cost number, which I think for staging hasn't been updated but should be on the live version. And then beyond that, we've got some of the other drivers. So we spoke about sickness and retention earlier, and Anna mentioned that when we start getting more structured and standardized information from e-rostering systems, we'll show some of those other non-working time metrics, either in here or in its own compartment. We're still deciding on the design for that going forward. Also some stuff on staff survey. So the 2018 results came out fairly recently, so we should be updating that relatively soon. And also have some information here on data from patient safety thermometer. I know safety thermometer is not always the best data set, but like with most things in model hospital, this is very much meant as a starting point for something to look at, and then revert to your own data and think about what you have locally that may inform this a little bit more or address some of the concerns that people at board level who've looked at this will say, okay, well, can you do a little bit more digging and see what's out there? And some information on detox as well. So I promised to look at the ward level numbers. So if I jump over quickly, I think we still have the issue where the data has not been anonymized, so I will scroll down very quickly to the area that shows me the care hours per patient day. And there's also, actually if I scroll up very slightly, some stuff for friends and family test and safety thermometer. Now the issue we have here is if you did want to triangulate the three of those things together, whilst trusts have their 3-letter trust codes and sites have their 5-letter site codes, wards don't have coding. So if you name a ward Ward A in one data set and you call it A, just A on another data set, they don't match, and as a result we end up with trouble trying to get data onto model hospital. Our master data set is the safe staffing data set, so we've got an issue here where the trust has named it something here but not named it the same thing in the finance data, and as a result we have no finance data available. But what I'm going to do is if I click into a metric, so I've got this set to, don't know what happened there, for intermediate care. And as I said, we've got some information here around, helping you understand what that data is. Usually has some links to additional guidance as well, and a little bit around the methodology. So I'm sure most of you are fairly familiar with CHPPD, so we exclude certain types of wards. We are primarily looking at inpatient wards here. And what these charts above do is helps you do comparisons with trusts, other trusts who also provide similar services. So in this case, we're looking at intermediate care. We don't show every single ward in here. We show an average of the wards. If I picked, say, general surgery, you'd have God knows how many wards per trust, and you'd end up with hundreds upon hundreds of columns, and then suddenly this graph becomes unmanageable. So we settled on showing averages instead. Obviously, if you're concerned that you've got wards that are assigned to a given specialty but have very different CHPPD figures, firstly, make sure you're satisfied that they are assigned to the correct specialty. So we had people assigning ITUs to general surgery, for example. They obviously don't, well, if they serve patients who are involved in general surgery, I can understand why you might map it to that, but I think about 3/4 of trusts make sure it gets mapped to critical care medicine 192. But again, it's a useful starting point to see where do you sit relative to other organisations, and is this something you need to be concerned about? Are you ensuring that you have enough staff on the ward to deliver safe care for your patients? How does this look if you triangulate it back to your planned data, and how does it look over time? So if I switch to, I think I can do trend line on here. Which isn't very helpful because I'm guessing the ward name changed partway through. But if you had ward name consistency, then you'd have that data going back further. You can also do a comparison for wards within your organisation. So again, here's your ITU position highlighted again. That is the column on the far right. But you can see whether, is this a systemic issue if you do have an issue on your wards, or is this something that's very specific for a given specialism or a given ward? Now, I'm going to jump over and say into one of the service lines, and I'll go into general surgery. So if you did want to look at staff numbers for a given specialty, we do break these down into here as well. Again, driven by ESR, you get your overall staffing numbers, a breakdown for different groups, and also your whether the staff are qualified, or also for, if you're looking at obs and gynae, you'd also get midwifery split out within there as well. And we were talking about the overall skill mix number in your workforce analysis. Well, this will give you a little bit more detail behind that. We also have data on staff costs. So how does your average salary look compared, or average cost, I should say. It's not just your salary, it's your on costs as well, your national insurance, your pension costs, compared to your peers. I will note that we do strip out the HCAS in this, so that if you did have a London peer, it should be comparable. But obviously, there could be other drivers of higher pay as well. For example, if you had lots of people working at their top of their band, it may well be justifiable that you have a higher cost if you have a high retention rate, for example. And you probably prefer having a higher retention rate to having a low salary cost and then plugging a lot of gaps with bank and agency instead. And there's some other information in here around the actual length of stay for patients, whether you're meeting suggested day case rates as per the BADS benchmarks, some information around discharge rates, if I move towards the bottom. So this is just a ratio of your admissions to your discharges, and looking at whether you're sort of discharging lots of people on the Monday, and that means they've stayed for overnight on the weekend, stayed over the weekend when actually they could have been discharged sooner had there been processes in place to deal with that. We don't currently do anything around comparison to EDDs, because I don't think we have a national data collection that looks at how well you're doing against sort of, measuring your expected discharge dates, but that is something that's being investigated by the team who sort of looks after the inpatients elements. A couple other bits to show you as well. So temporary staffing. There was a very, very tight leash held on access to temp staffing, just because there's some quite sensitive data around cost per shift. There's sort of commercially sensitive data around the charge rates that certain agencies will be charging to different trusts, even if they're in the same area. We are opening access more widely to this. And if you did want access, the first place to start is with your trust ambassador. So I think all acute trusts now have an ambassador who has access to pretty much every compartment in Model Hospital, including this one. And they can also point you to how you gain access for other compartments where you may not have them already. But if I go into some of this very briefly, so it just gives you a sense of your overall staff expenditure, your performance against your agency ceiling, and looking at how your costs look compared to your total in terms of bank and agency, split by staff group as well. So these all come from the financial returns rather than the agency, the weekly agency shift data. But you can see you've got your nursing data split out there as well as other staff groups. For your shift data, again, you do have it split out for your nurses, and you can look at number of shifts being delivered per week. So we take a 4-week rolling average for these numbers, and so it's the 4 weeks up to that date. Your cost per shift, which takes a combination of the finance data and the shift level data. And then if you have high numbers of shifts or a high cost per shift, particularly for a given staff group, then you need to, or I would suggest that you'd look at what could be driving that. So is that an issue of complying with the wage caps? Is it a problem where you've got lots of people coming for overnight or weekend shifts? And unfortunately, we don't have this data split by specialty and ward at the moment, although we are lobbying the agency team to start collecting some of that. So it would be more useful in terms of being able to find those flags early on and have that action on the ground sooner, rather than looking at this, then having to do the extra analysis yourselves and then taking that action. Just be mindful of some of the figures that are on here. Like I said, because we use a combination of the finance data and the agency data, you can end up with weird numbers like that, where the finance data seems to suggest that you're spending lots and lots of money, but the shift data has very little data in it. So just make sure you're triangulating some of that with your local teams as well. I think I'm coming towards the end of my time. I was going to spare 10 minutes for Q&A, although I didn't realise we had a Q&A after, so I'll just quickly mention a few of the developments we have. So. Mm-hmm. Yeah, it can indeed. So. Certainly. So for the CHPPD, actually this is one of the future developments I was going to come on to, is we are looking at, you'll notice these are blue metrics. So a green to red metric means, well, it's quite obvious, green is good, red is bad. A blue metric basically means we can't make a judgment call currently based on the data we have available to us. And the issue with CHPPD is, we've only been collecting good data for a couple of years, data overall for about 3-4 years, and working with Anne on looking at how we can start judging what good looks like for a CHPPD, and essentially trying to develop what we're calling specialty ranges. So, are you somewhere so low down that you're not delivering safe care? Are you so far up the scale that you're, in fact, if I open that up, it'll be a nicer demonstration. So far up the scale that you've got so many staff on the wards, you've either got diseconomies of scale or you've got staff that you can move to another ward where you have lower CHPPD numbers. And compare that to what you had set as your establishment. Compare that also to how you're filling that as well with bank and agency. We are actually going to be publishing a different version of these types of charts, which shows proportions between substantive bank and agency based on some of the data we get through safe staffing and from the finance data. But we are, long-term looking at turning this into what will probably end up being a red to green, back to red type chart. I think there's still a fair bit of work to go on that, but sorry. Yeah. No, that's fine. Mm-hmm.
So some of the trusts on the right, in the highest column, includes allied health professionals in their numbers, whereas some of the numbers on the left, nursing staff and care staff. So until there's a standard baseline, I'm very aware that regulators are starting to use this data.
Yeah.
And I'm very concerned when we start talking about red to green to red.
Yeah. So on the point of common numerator and denominators. So that's part of the reason why we're updating the guidance around it, is we are going to be collecting in a more standardized way the AHPs who are assigned to wards. We try to be as clear as possible that as to what the inclusions and exclusions should be, so that we have that standardized approach across different organizations. And that's also why we suggest looking at the ward level data as well. Because you will have a massive skew in the figures depending on what services are being delivered, and as a result who is delivering those services. But it should be common across all organisations presently that you are excluding daycare wards, that your nurses and AHPs go into separate columns in the collections that are coming up in future. That there are separate columns in there for your registered and your unregistered, for senior nurses who aren't delivering care, that they are excluded from these figures. A lot of this is already written in the guidance, and we have the link to the guidance in there. And I think for the red to green to red needs a bit of testing, road testing beforehand anyway, so I wouldn't worry too much about the job title you had on there previously was a job as a regulator within the NHSI. Yes, I am well aware that people like me are looking at this figure, and that's why I'm encouraging you all to sort of look at Model Hospital more holistically, or encourage the people who are telling you there is a problem with your CHPPD data to look at the wider picture and correlate it with some of the patient outcomes and with the retention rates and with bank and agency rates within your organisations. And that is what the specialty ranges will hopefully achieve as well. You know, it may look like a high number presently, and your finance director is breathing down your neck saying this is definitely too high because it's too high compared to our peers. And then when we create a specialty range and you find that high number is actually a good thing, then you may well come back with better ammunition against those who are trying to suggest otherwise. So just to go through the last couple points, where am I? So we've got a couple other links on here when the slides get circulated if you wanted to have a look at some of the other information. I've not touched on mental health and community as well, but we've had very rapid development for those trusts too. So if you are from a mental health or community trust, I strongly recommend you look at that. If you're an acute trust who delivers community activity as well, the community, the CSDS will be circulated soon, and some of that information will be presented for your acute trust as well as for the community trust. So you'll have a more accurate representation, because that is something we've been questioned about a lot, as people who deliver integrated services. And also to make a point that we have improved on the speed at which we respond to queries. So if you do have any questions, please do send them. to the address listed there. I think we've got ourselves down from about a 3-week response time to about 1 week, which is still higher than we want to be. We want to be around 3 days, but we are certainly doing a lot better than we were previously. So apologies to those of you who had been waiting long times. We were just moving between different feedback systems, and we now seem to have settled on something that works a little bit better. Right. So yeah, I'll be around for questions later, and I think I'm sticking around till about 2 o'clock. So if you have any queries throughout the day, feel free to grab me. But otherwise, I'll pass on to Lorna.